Good morning. It is Tuesday, January 25th. Welcome into the Morning Medical Update. Today, we are talking about drug shortages and pharmacy issues caused by the Omicron variant surge. Rick Coldry, Vice President of Pharmacy and Health Professions here at the health system, is joining us. Also, Dr. Sean Coomer is with us. He is Vice President of Perioperative Services, and he's also a transplant surgeon here at the health system. He's going to tell us the impact this surge is having on surgeries and procedures. Also, our Chief Medical Officer, Dr. Steve Stites, is with us. He's going to be with us for a bit this morning to answer some questions. We'll get to him here in just a moment. So make sure to get your questions sent in to us on YouTube, Facebook, and the Medical News Network. You can find links right there on your screen. But first, as always, let's get to our COVID count with Medical Director of Infection Prevention and Control, Dr. Dana Hawkinson. Good morning to you.
Hi.
Hi.
Today, 117 active infections, 27 ICU patients, 16 of those on the ventilator. We still have 98 additional patients meeting that recovery period. A total of 215, again, 117 active, but I think that should be tempered with the fact that we know we had 6 deaths in the last 24 hours from COVID, and so I think that is a harsh reminder of kind of everything that we've been dealing with. Overall, 46 deaths so far in January.
All right. Well, if you are just waking up, we have a few updates this morning. Shawnee Mission School District is requiring all students in that district to now wear a face mask in school. The school board approved that change last night. This applies to students, teachers, and anyone who may visit any of those district buildings. This rule will be in effect until February 15th. Also, those in Prairie Village can sign up starting today on the city's website for free at-home testing kits. The city is only requesting those who need one to sign up because of the limited supply. I want to check and see first if we have any reporter questions on the line. We do not, but I got one right here. I got 2, Dr. Stites, for you. Good morning to you, by the way.
Good morning,
okay, so hi. So KCTV5 has a question. Just thoughts on Pfizer starting its clinical trials on its Omicron-specific vaccine. What do you think the time frame will be? Will it be similar as far as the rollout goes? What do you know about that?
Yeah, so Pfizer announced yesterday and that they are going to start doing some more Omicron-specific vaccine trials. They have it divided up into different groups, and they're going to look at a whole new fresh series with the Omicron-specific vaccine, as well as either a 1 or 2 shot booster regimen for Omicron. They're probably going to launch those trials soon, likely in March. Then they expect the data to come back relatively soon because of the rapid rise in Omicron. We'll see how that plays, in part because Omicron is decreasing in many parts of the United States. You know, it's interesting. We've got a map. If we can show it for just a minute, guys. This is the rate of rise of Omicron-specific cases throughout the United States. What I want you to note is that the state that now has the highest average case per capita is Kansas. And what that means is that you look at the other parts of the United States. The Northeast has clearly shown the hook, and it's dropping rapidly. You look at the South and Midwest, those areas are also dropping. But if you look at Kansas, highest increasing rate of any state in the United States, not exactly the honor you want to receive. We know that Missouri is the least vaccinated state in the United States. So I think those are the things that are setting us up for a difficult outcome, and we're seeing that in our own data. We've had a lot of deaths recently. The idea that Omicron is less severe is something we probably have to take a closer look at. You know, before, our ICU length of stay was longer than it is today. That's good news. The percentage of ICU patients was higher in the prior waves than it is today. That's good news. But the bad news is that you can still die with Omicron, or from Omicron, or all about Omicron. And I think what has gotten out there is the idea that this is just oh my cold, and that we don't have to be concerned. But oh my gosh, actually we do. Omicron, while perhaps less severe in overall for all patients, is very severe if you get it and you end up in the hospital, and it still causes a lot of deaths. When you do a close inspection of our deaths, it's a mixed bag. It's people who came in with trauma and also had COVID. It's people who came here only because of COVID. Most of the deaths, though, are in people who either are very remote from their initial vaccination, like 8, 10, 12 months, have never been vaccinated, or had a really severe underlying disease, suggesting that their immune system is very compromised. It should be a warning to all of us that Omicron is still very dangerous, which is why I think Pfizer is pivoting. So to get to that exact answer, I think it's great that Pfizer's pivoting. I know that Moderna is planning to do the same thing. That's from prior releases that they've talked about. I think the struggle is going to be as the numbers start falling in the United States to make sure that you get the vaccine trial early enough that the data is A, still relevant, and B, still obtainable. So, I suspect they would be or wouldn't be, but that's just something we want to keep an eye on. I don't think that it would be ready, though, and I believe that the earliest predictions are it would be late spring, early summer before that new vaccine shot's available. So I don't think it's going to be something we're going to know the results about right away, probably April or May, which means it would be May or June before it was actually in shots. And at that point, the Omicron surge the Omicron surge could be done at that point, right? Because we are already seeing that tail hook go down across the United States. Unfortunately, it's not gone down in Kansas.
Mm-hmm. Yeah, I agree exactly. What we have seen is new variants arise, new variants sweep through. Now, obviously, Alpha started with the major one that started to sweep globally after that ancestral strain, and then it was Delta globally, and now Omicron. In the pockets of certain geographic regions, we know that other variants have stepped up. We knew that Moderna was planning and trying to do that original South African variant. I don't remember if that was Beta or Gamma, one of those, that 1.351 variant. That ended up dying out or getting displaced and replaced by another isolate. So I think moving forward, I think that's great because we know that Omicron, the spike, is so antigenically different, in the way it looks to our antibodies and our immune system for that aspect. So maybe using that in the future, but also keeping the original ancestral spike mRNA vaccines is something important too, or maybe even delivering both of those with one injection as well. So we know other vaccines, you can deliver several different types of antigens with that. So I think that's important to note, and we'll just kind of see how it goes, but I agree with you, Steve.
And I think
Dr.
Hawkeye, just follow up on one quick thing. I think Hawks raised a good point, whether or not the vaccine is going to be mixed or not, and I suspect that it will be. They're not going to just aim it at the Omicron variant. But I think the other thing is that's important, this question about boosters. The data came out as really strongly yesterday and has been coming out more and more about the importance of boosters, and without boosters you're not nearly as well protected. And Dr. Hawk, just to say, that's sort of the influenza story, right? 6 months after your influenza vaccine, even though it's the same strains out there, you've really lost a lot of the protection from the influenza vaccine. So we really shouldn't be surprised that this is acting just like that. And it's 6 months kind of ends that time frame, and you're gonna have to think about getting the booster, otherwise you won't have as much protection. And we'll start talking more and more about that. We're seeing that same pattern emerge in our own data.
Mm-hmm. Yeah, and along with that, with the antibodies, we know your antibodies decrease and contract. That is natural, what happens with our immune system. But we do have the saving grace, and what we have found out, just as you alluded to, Steve, the new data that supports the vaccines we have right now, it's because of those other immune cells, that other arm of our immune system, our T cells that continue to work because of really conserved areas or unchanged areas on that spike, which are still recognized by our T cells. Again, just as you said, with the booster to help reduce your hospitalization, severe disease, and death. Because of those regions, we can then continue, even with this vaccine, to help provide protection against severe disease and death. And so I think that's important to know. These vaccines continue to work very well, especially if you are up to date with your vaccination, meaning fully vaccinated with 2 doses, and then having had that booster as well.
And can I just say, Hawkeye, have you been back here in Studio B before? It's kind of like a little man cave back here.
Yeah, I used to use it as my office. So it's good.
No, it's not bad. The only problem is the camera feels like it's closer. I can see my bald head. I look a little more like Coomer and Coldry than I really remember or that I thought I was. And I'm not sure I like the camera view back here as much, even though it is kind of a feeling for a man cave and good one to have to make an early and rapid escape. Sorry.
Yes, we will let you go.
Yeah.
Good observation. I'm glad you got a different view this morning. We like it. But what I think the guys are loving, you're actually forced to sit up straight. It's not the typical Stites leaning over.
I can't lean, and I can't rock as well in this chair.
I know.
I'm going to talk with Logan and Anthony about that. And I think we need a rocker in here.
It was all by design. We're going to keep you in check today.
Yeah. Jess, was there a question before I have to head out?
Yeah. Let me just get 2 quick questions. So, and you may have answered this with the graph that you showed, but Shane over at KCTV5, can you just explain? So, are we seeing a downslope in hospitalizations in the metro?
No.
Okay.
No, we're still in upslope. Our numbers are still rising. We keep saying, okay, we think they're plateaued. Well, if they're plateaued, they're plateaued. But it's interesting. The rate of hospitalization, I don't know if you guys if Logan and Anthony could pull their magic and look at the actual state by state data that's in the New York Times information. If you look at or even the national, just the overall national one's fine too. The what you're watching, that's the heat map. Look at the state by state data, because what you'll see is that the rate of hospitalizations is different than it was before. The rate of hospitalization is going up, but it's going up at a lot slower pace than it did during the other crises. But a couple of things about that. First of all, the actual spike, if you look at it, is much more dramatically up now than it was historically. And if you look at our hospitalizations, they historically with other waves are just offset a little bit more by 1 or 2 weeks. Yeah, there you go. And in this case, what we're seeing is the rate of hospitalization is still going up. It's just not going up as rapidly as it did at the other times, and there's going to be the time displacement's funnier because this upslope is so much higher. But what I would say to you is, and you can see it in our numbers, right? We just set a new record today for the most acute, for the highest number of cases we have. Our active infections one time, where I think we got up to 123 or 115 this morning. So we're staying really high. I do not believe that we're really seeing a big drop off right now. It's much too early to say that. And with the overall case numbers in Kansas rising like they are, we should not expect the decrease in hospitalizations yet. Part of our challenge, though, is that the rate of hospitalizations are rising. You had it by county. In Kansas, it's most rapidly in the rural areas. And we're having difficulty getting patients hospitalized in the rural areas transferred to the major academic or the major urban areas because there's no beds. And so we're still left with the same dilemma of how you're going to take care of patients in rural areas. We're going to hear more about that tomorrow on open mics because we have our 18 chief medical officers throughout Kansas and western Missouri on with us. I think you'll hear a real story about what's going on out there then.
All right, last question, and then you can scooch. Okay, Fox 4 has a question asking, what does a decision by the FDA to revoke monoclonal antibody treatment for Omicron mean? Will it no longer be offered?
No, that's not right. The stem of the question is wrong. The monoclonal antibody therapy the FDA is saying don't give anymore is the one that doesn't work. It's not the one that's for Omicron. Yeah. It was the one that was for Delta and prior. And so that actually the stem of the question isn't correct. What happened is the sotrovimab is the one for Omicron. The others, and because 99.5% of infections right now in the United States are Omicron, those other antibodies don't work. And so as a result, they're saying don't give them anymore. And that's really the comeuppance of it. It's not helpful therapy. It's essentially giving a sugar pill. And so at this point, there's no reason to give them because we're not seeing any Delta as a new infection. And so Hawkeye, that's why, I mean, if you read the whole statement, that's really why they pulled the Regeneron products and the other products off the market because we're really only left with sotrovimab that can be effective against Omicron.
Yeah, I'm kind of curious as to why they released this now. I mean, this is somewhat old news. We knew about this for the last week or 10 days. We haven't been using those antibodies for quite some time now when Omicron was becoming prevalent in our region, and so that's nothing new. I think the major impact, though, is going to be overall supply of monoclonal antibodies to treat patients. We know that these monoclonal antibody treatments do work to prevent hospitalization in those severely at risk. So that's the big issue, is really the supply. But again, this is nothing new. Earlier in 2021, we had an EUA for the Eli Lilly product, I believe, that was revoked. However, when Delta became predominant, it was able to be backed on because they found that those monoclonal antibody combinations did actually work. So there's nothing to say that in the future they can't use them if they find that the monoclonal antibody has activity toward that variant. Again, it's already happened once in the pandemic. It may happen again. They may be able to bring them on. We know those Eli Lilly and Regeneron products work very well. It's just you have to make sure that they are specific enough to bind and neutralize that virus. So again, nothing new, and we knew about this for a while. The health system has been only using sotrovimab now, Rick, for 2 weeks.
Yeah, a couple weeks.
Yep. I said two other quick thoughts about that. I'm going to miss saying bamlanivimab because it's cool to say, and so it's off again. Secondly, the FDA also authorized Regeneron for outpatient use for early cases of COVID-19. And Rick will talk a little bit more about this. The data looks really good, but it's also harder to administer because it's an IV infusion and you have to give it daily for 3 days. And setting that up in an infusion center where they're already really busy right now, that's a challenge. And so we're working to get that delivered on the outpatient side. And then the other point being that Paxlovid and Molnupiravir, the two oral therapies, especially Paxlovid, looks so effective, but has a long list of drug-drug interactions. And Molnupiravir has some really significant issues with with women who are pregnant. But neither of those drugs are in good supply right now. And so that'll be a challenge. I think Regeneron offers the most immediate hope outside of Sartrovimab on the outpatient side to a larger number of patients. The problem is it's going to be harder to deliver on an outpatient side because people have to come and get it every day for 3 days.
Anything to add, Rick?
No.
I thought we were having a crosstalk. Okay, so
Hey, I gotta go, but I want to leave it to my forehead brothers.
Okay, I will take good care of them in here. Thank you. We will see you tomorrow.
Yes, ma'am. Be back.
All
See you
right.
then.
Have a great day. All right.
Bye.
Rick, I'm going to get to you here in just a second because I know I'm going to lose you here, and then it'll just be down to us, Dr. Coomer and Dr. Hawkinson. Okay, so scarce medications. This is a reality in many places as the COVID surge rolls on. We've been talking about it. A recent article in the Times Magazine it highlights this issue. So this was at UPMC Hospital System in Pennsylvania. The staff can treat fewer than 1,000 patients per week with infused monoclonal antibodies. That is down from as many as 4,000 earlier in the pandemic. That is because only the GlaxoSmithKline, these are big words for Mama this morning, these appear effective. This is the one only effective against Omicron. So the period is it's just in short supply. So Rick Holdry, VP of Pharmacy and Health Professions, let's start with you. So we here at the health system, we know that we're very blessed with the ability to get our supplies from different suppliers. Right. We can also make them here and compound drugs here on site. But just talk about shortages around the country, how COVID is affecting that, and how that's trickling down to us.
You bet. So I divide shortages in a couple categories. So what Dr. Stites was just talking about and what you're talking about, the products that are in short supply are really a matter of supply and demand. So they're brand new. They've never been made before. Manufacturers don't have enough capacity to manufacture everything that's needed. And that's just the nature of the new drugs. Both the product that you're just talking about with the slide, as well as the oral, the COVID pills that everyone is excited about, that Dr. Stites was talking about. So it just takes a while for manufacturers to ramp up their production of those drugs, and the demand is, as you know, in the middle of the surge, extremely high. So that's one category. Okay. The other category is far less exciting, less sexy. So I don't know if we can get a picture of this here. I brought show and tell today, Jess.
Okay. I like
it. This is a very unimpressive small vial of sterile water.
Okay.
So these kind of products are also on shortage, and it may not seem like a big deal. Like, what do you mean water? Like, how much do we need? What do you need water for? Well, like Stites was talking about, if we do an infusion, the drug doesn't always come as a liquid. Sometimes it comes as a powder or a dry product. So you have to mix it with something before you can infuse it. It's either water or saline. And when you don't have those, it makes it really hard for you to be able to mix those products and get them to patients.
So something as simple as that.
Something as simple as, and this, the explanation for new drugs that are in high demand is frustrating but understandable. This is like milk and bread and water and eggs. You don't, for in the medication world. So when you don't have that stuff, it's really frustrating.
So those are the staples, and it's important to have. You're missing one.
You got it.
It's a big deal. So what do you do?
So it's a day-to-day shift and scramble for our teams. So this is one size vial. You can also get in a 50 ml, a bigger vial, or a medium-sized vial, and so then you just have to change how you work and change the products on your shelves. Also, we have a very complicated information system here at the health system, as you might imagine. So every time we change products, we have to change the information in our information system because it has to match exactly. When you give a drug to someone, you have to record exactly what product you gave. So you have to change that every time you change what the product you use. So there's just basically a team of people, and this is with all kinds of supply chain issues, but in medication world, it's been going on for 10 years or more, who work every day to shift around and find products and get ahead of the curve. Sometimes we get down to as much as a few days supply of a product, and then more will show up, or they'll find an alternative source. But it's a day-to-day fight.
And this has happened way before COVID. We have shortages
Way before COVID.
So kind of compare those, what we are seeing now to what we would have seen, on a regular.
Essentially, it's the same kind of issue on steroids, because all the other supply chain issues that we're facing, Jess, these products are not immune. So if you're already short for 5 or 10 years, and now we have supply chain issues throughout the world and throughout the nation because of COVID, delivery issues, production issues, all those things, it's just made it worse.
So we try to keep the impact off of patients, but, will patients feel this? Are there alternatives? How will the patient feel this on their end?
So essentially, not really much, because it's the proverbial duck on the pond, right? You can't see anything, the duck's gliding along, but underneath the legs are going like crazy. So that's kind of the way things are working. It is possible that some patients may have rescheduled or delayed treatments, because if we just don't have the drug, that's what we have to do.
So then how does this impact, when we talk about the impact that we're just having with this surge, staffing and so many patients, just what are we feeling? How does this impact our staff when things like this aren't moving down the chain?
It is just, it's just one more thing that makes you tired. When you wake up in the morning and you're trying to take care of people, and I know Sean and Dana can speak to the same thing. You wake up in the morning, you're trying to just come in and do your job, help people out. And like you said, you're going to go make eggs and you don't have any. You know what I mean? You just, okay, now we got to go figure this out. We got to solve this problem. So it's just one more thing that I think leads to burnout and frustration in healthcare.
So we talk about moment to moment, day to day. It's no different in pharmacy.
And we could go on. It's no different in pharmacy. Lab has the same issue. Lab tubes to draw blood are in shortage.
Yeah, tell us what's going on in the lab, my lab guy, while you brought it up.
No problem. On the COVID testing side of the thing, our lab is doing great. Nationally, supply of blood tubes is a problem. And this is really related to both manufacturing and supply chain issues where, we can't move things from point A to point B throughout the United States. So the lab has had to change the types of blood tubes they're using to draw blood, I think 2 or 3 times now, just to get tubes to draw blood. And so then what happens on the back end is right now, the tubes that we can get don't fit on the automated testing equipment, so we have to have people manually transfer the specimen to a different tube to put it on the automated testing equipment. So
this is why you're always so busy when I try to track you down. Now I figured it out.
It does keep us busy.
It does. All right, Dr. Sean Coomer, I know you're busy as well. How are you?
Great. How are you?
I am good. Okay, so tell me, when we have medication and pharmacy shortages, how does that affect when we go into the OR?
Yeah, well, it's very, very interesting. Rick and I were just dealing with an issue last week. We didn't get nitrogen gas delivered to us last week. With 78% of the air is nitrogen. Why should this be a big deal? Well, obviously it is a little bit more complicated than that, but that runs all of our power tools. If you think about that in the operating room, it really, that was a major issue. We were making plans to shift nitrogen from all sorts of areas across town back to here. Luckily, we got a shipment that came in on Fridays, so we averted that. But, these are the things that we're dealing with. It's just you get surprised every day about something new that happens that really affects the whole domino principle. It just affects everything down the road.
Right, and the nitrogen shortage was super fun because we didn't get told that they weren't coming.
Right.
We found out by a lack of product.
Right.
that we weren't getting nitrogen. So, and we're not actually quite sure how that happened. I know the delivery driver may have been sick with COVID, or we haven't.
So you're having to figure that out on the fly like that.
Yes.
Yep.
Yes. Yep.
Not fun
Nope.
when you've got so much going on. Because last week we deferred about 50% of surgeries. Are we back up a little bit?
So more than that, actually, it's been a very inauspicious start to 2022. Not only, obviously because of COVID, but starting January 3rd, we reduced our surgical and procedural volume by 50%. So the first 3 weeks of the ORs have been 50% decreased. This week, we're down 25%. So we're not really sure how long that's going to continue, but it's sort of 2 problems within the pandemic. So, initially we did, our numbers were setting records, right? 213 cases today here at the hospital, and 120 some are active. That's a problem. But furthermore, you talk about staffing. A lot of our staff got sick, right? And you talk about just peri-op procedural, you talk about the inpatient staff taking care of patients was really difficult, right? So we had a severe decrease in our peri-op staff, so we couldn't open all the rooms. So we had to decrease the cases. And then on top of that, we have decreased ability to take care of the inpatient population, whether it's after surgery or not. So we had to kind of shift our man resources around all over the hospital.
So that's a full balancing act.
Yeah,
And I
really.
remember when we first talked at the start of the pandemic, a lot of why we were just decreasing is because there were so many unknowns and there were so many patients, and safety was an issue, and just kind of figuring all that out. Now it's staffing is the main reason.
Yeah, I mean, every shutdown has been different,
Right.
right? I mean, initially it was we didn't have enough PPE. Then it turned in we didn't have enough paralytic medications for our operations. Then in turn we had a blood shortage, which sometimes that comes up again. And now we don't have nitrogen or we don't have people. There's always something new, and you're right, it leads to burnout, but it also leads to a lot of creativity, which I give our health system and a lot of health systems credit for doing. They've really shifted people around.
So, and speaking of that with staffing, we've added 30 traveling critical care nurses to our team. How is that helping and impacting?
Yeah, so not critical care, it's
Okay.
critical agency staffing. So
Okay, what does that mean?
That means we have 30 more folks up in the ranks, up on the floor to help out. So that reduces that nurse to patient ratio, which gets it. Safety is number one, so we want to make sure we have a good ratio. That also allows us to do more cases, to accept people in transfer center, to handle the unexpected bumps when people come into the ER or the traumas that show up. That will allow us to do that. It gives us a little bit more cushion. Doesn't make us totally comfortable, but just a little bit more.
It helps alleviate
Absolutely.
in some of those
And
areas.
that's some of the creativity that's
Right,
going on.
and again, moment to moment. So a lot of people ask questions, the community asks just about safety in the OR. Again, you've been doing it safe since the beginning of the OR time. So explain people why you feel so safe, why staff, why people coming to get surgeries and procedures should feel safe inside an OR.
Yeah, it's the ORs and procedural areas has always been the area that is the most sterile, right? And certainly there are areas in the hospital that are compounding and pharmacy and so forth, very sterile. But when you talk about the OR, everybody's wearing masks there all the time. That's what we do. We wear masks. And not all the time before all this that we were wearing masks around town, but that's a whole other issue. So we're very careful. We do pre-op testing for those major cases. So, and when we have people that are COVID positive and we're able to defer their surgery a little bit, that helps because then it decreases their morbidity and mortality. But there's some cases where we have to get things done if they're COVID positive, and we take every single precaution, not only for that patient's safety, but also our people's safety.
So what type of surgeries might you defer?
Something that could be pushed off a little bit, right? So if you have a hernia surgery that we could potentially, safely push off, that's quote unquote elective. I hesitate to use elective because most surgeries aren't elective, meaning that hernia is not incarcerated or something, an emergency. We can push that off a couple weeks, just to make it a little bit safer for the patient.
Rick Holdry, I know you've got a scooch.
I do.
Just a quick final thought. What do you want folks to know just about the work you're doing and what does the community need to know?
What I would say, and in particular about shortages, which we talked about today, is, thanks for asking the questions, being aware that it's just an extra burden on our teams that are taking care of people. And but don't be afraid that we're not going to have what you need. We will figure it out, and we'll get you taken care of. That's what we do.
All right. Thank
you
you
go.
so much for being with us this morning.
Thank you, ma'am.
All right.
Have
We'll
a
let
good
you go.
Don't forget your sterile water. Get that back.
Yeah.
Thanks, Rick. Couple more questions, and then we're going to get to some community questions. So just when do you think things will return to the new normal when it
Right.
comes to what we're seeing inside the hospital, your world, and beyond?
It's interesting. I talked these issues about people resources and talk about our community problem with the number of people that are getting sick. So like I said earlier, and everybody else has said, our numbers are up around the community, around the United States. The heat map was showed earlier. All red. I mean, this is bad. But we're starting to see our employees that have gotten sick and returned to work has really decreased significantly, which is great. So we can do more. we still have a significant number of people in house. 20-25% of our population is COVID positive, whether they're here for COVID or they happen to be COVID after a trauma, whatever it might be. So I'm hoping here in the next couple weeks that we're going to be a little bit back to our pre-Omicron spike, if you will. So back to where we were back in November, December. That's what I'm hoping for. But that's only that's a crystal ball, right? We don't know.
We always have the crystal ball question. Will you help me tackle some of these community questions with Dr. Hawkinson? Okay, let's do that. Rick just left, so Dr. Hawkinson, I'm going to give this one to you. Let's go asking. I know other hospitals are recommending patients take vitamin C, D, and zinc to help boost immune symptoms. Are we doing that? In what case would you recommend that? I mean, certainly not as a COVID remedy, correct?
I mean, I think for your general health, if you want to take those supplements over the counter in the prescribed doses or as directed, I think that's fine. I really don't believe, and certainly the NIH would agree with that really there's no evidence for or against taking that for treatment. I think if you wanting to do it, most American diets do get a lot of that. I think vitamin D is a very good and healthy supplement that all Americans probably should be taking because most all of us are vitamin D deficient. One of the major sources of vitamin D is the sun, so you have to be careful about that because of skin cancer. Shout out to my dermatology colleagues out there. But understand that if you want to take some of those vitamins as they are prescribed and directed, I think that's fine. As far as COVID treatment or prophylaxis, none of those have proven to be any benefit. So
Sarah's curious, can someone who has had quadruple bypass heart surgery get a fourth shot?
I would say, yeah.
What are we saying to people who
I
have
mean,
had major surgeries?
if we're talking about a fourth shot, right now, only 3 have been recommended. Unless you're immune suppressed, then you should get those 3 and then that additional booster, which would be your fourth shot. But if you're not immunosuppressed, I think ultimately you can probably get as many as you want, and it's really going to be fairly safe without adverse events. The question is it needed? Is it essential? Right now, the best data that we have would suggest that it's not needed. So we already have a problem with people wanting to put at least one vaccine in their arm. I'm happy there are those that want to put more. It probably is safe with no adverse events, but I don't think you need to right now. We'll certainly wait for the data, and we do understand and know that Israel has been one of the leaders in that early data for additional dosing. We know they are giving fourth doses to a large proportion of their population, but we will see if it's really needed. So stand by. But overall safety, I don't think there's any risk to that.
Any precautions for your surgery patients, your transplant patients when it comes to the
shot?
shot?
Like Dr. Hawkins said, this is, whether you have a quadruple bypass, whether you have aortic aneurysm fixed, or any procedure, that doesn't exclude you from getting a booster and what the recommendations are. So, and it doesn't mean that you necessarily need more. It's, we'll have to see how the recommendations fall out going forward. I think everybody has an idea, but we'll have to wait for the final word. But it certainly any surgery should not exclude you from that.
Dr. Hawkinson, Kathy needs some advice if you could help her out. So she's, her and her daughter, her husband, they have tickets to a big concert, a big crowded concert downtown. They're both teachers, so they mask every day. Just doesn't know whether she should go or not. Are people at the place where they really need to go, let's stay away from those indoor big events?
Yeah, I mean, I think you have to consider your individual and specific situations. What do you do? I think that is a very good thing. So a teacher, we know that teachers are in short supply right now because a lot of them are out. Other people who may be essential, and I think essential covers a very broad spectrum there. So understand what you do, what happens if you get sick. Also understand your health situation. Are you up to date, meaning fully vaccinated, and you have that booster? If you do have that, then more than likely you are going to be very well protected from hospitalization and death. But consider your comorbidities, things like age, weight or obesity, diabetes, kidney disease. Are you on immunosuppressive drugs? It is a very complicated scenario, and there are details in there and gray zones which you have to understand about. And then once you know that, then you just judge and make that assessment. Do I feel comfortable going? Certainly wearing a mask. We know that people who are fully vaccinated and up to date and who wear a mask, even around others who don't, have a reduced risk of infection and, of course, disease. So that's important to understand those situations and then just judge the risks and the benefits of doing that thing, because we all do want to get back to life as we knew it and back to enjoying life and doing things. And so I think if you can protect yourself as much as possible, and that means vaccination and being up to date, but also in those situations, if you want to wear a mask, that's going to provide protection as well, then you should be allowed to be able to go out and do those things. But just make sure you're doing it in that thoughtful manner and understand all the risks and benefits that come with that.
I know, Dr. Hawkinson, I think people just like to hear you say, I think it would be easier if they could just call in and say, this is what I'm doing, tell me yes or no.
Yeah.
Do you get that question a lot from just people saying?
It would be great if we could all do that and everybody
would.
was fully vaccinated and updated with a booster. I think that would make everybody feel more comfortable. I think that would decrease the spread in some of those higher risk situations as well.
Well, I do. I think people are wanting to do it right.
Yeah.
Absolutely.
But they just don't know what to do.
Yeah,
But they want to get life back to normal, but they want to stay safe
Yeah,
and
and
keep
there's,
people
and there's
safe.
lots of things going on. There was that little Chiefs game the other day, and there might be another one on Sunday, I understand. So those are things people want to do. I get it.
All right, Joe Ellen has a question. Can you speak to the efficacy of the at-home test with Omicron and what might happen with the new variants? She also thanks you for your work every day.
Well, from what I understand, and there was a recent paper out of UC San Francisco that looked at the Binax 2, which I think is one of the more prevalent brands out there. And that showed that it was 95% sensitive in picking it up. So if you had symptoms and you tested yourself, there was 95% chance that you are going to be able to diagnose it correctly. They also do say, however, if you are symptomatic and you test yourself and it's negative, you may want to test yourself the next day or the day after that as well. I think there is some information going out there about that maybe when you're symptomatic, you need to test again because it won't pick it up at all. You know, unfortunately, what we do know is that you have the highest viral loads in your body 1 to 2 days prior to getting any symptoms to about 2 to 3 days after. So really, if you are developing symptoms on that first day or second day, you can test yourself. I think it's important to know so that you aren't out in society and spreading it unknowingly. And so I think that is important. But overall, the answer to the question is, from what I understand, is the Binax 2 test is about 95% sensitive in picking up the disease if you have it and you are symptomatic.
A couple more COVID questions for you and vaccine questions. Peggy's curious, if you need a booster after 6 months, does that mean I'm going to need a booster every 6 months?
Yeah, we don't know. The data is not out there. There are differing opinions. There are various opinions on that. Some clinical people would say yes. Other scientists and people who work in immunology and people who work with viruses would say no. It's that third dose that is spread 6 months from that second dose, really, that proves to expand your immune response. So unfortunately, we don't know, and I think we are waiting for that information. And the other thing is, well, if I'm getting a booster, why am I getting the booster? Is it to prevent disease, or is it to better boost and decrease my chance at hospitalization moving forward? And again, we know Israel is offering 4th doses to a large section of their population. We'll have to see what that data is. We know the data for 3rd doses against Omicron and hospitalization is very good and supports that. So the question is, we don't know, and I think we just have to kind of wait and see. But there are varying opinions out there.
Amberly says, good morning, Dr. Coomer. Thanks for all you do. Can you compare the number of liver and kidney transplants this year, last year?
So obviously it's a little bit early than this year, but nonetheless, we did go up quite a bit in livers, and our kidney transplants were pretty much on par, just down a little tiny bit. But we also do living donation for kidneys, so the total numbers here at the University of Kansas Health System are stable, maybe a little bit up. Nationally, the number of transplants performed across the country has gone up, and that's actually been secondary to the organ procurement organizations across the country actually doing a great job. They are working harder than ever, and we've had more donations because of their hard work. And some were already doing great work, and some were a little bit subpar, and they have stepped up their game this past year, which is good.
Even living donation, that is not something you would ever defer, right?
Well, no, actually,
could you?
We
is
have.
It possible? Okay.
We have, yeah, because you think about that. The living donation, that's the ultimate, surgery, right? I mean, they're not getting better after that operation. You're hoping the same. So we did push a few of those off a few weeks, but that's not elective for the recipient who's trying to get off dialysis or
Correct.
stave off dialysis completely. So those are difficult decisions. Those are the decisions we've been making over the past month and longer.
And it's patient to patient based on
Yeah.
where they are.
Absolutely.
Last question. Sarah wants to know, is heart disease immunocompromised? Is that an immunocompromised type of issue for someone when it comes to COVID? Dr.
We wouldn't
Hopkinson?
consider that immune compromise per se. We would consider it a comorbidity, and certainly having COVID infection or having SARS-CoV-2 infection can exacerbate that heart disease, but it is not considered an immune compromising condition.
I'm sorry, last one from Melissa. If you had COVID again, how long should you wait to get your booster?
That is a very good question. I don't think there's any specific guidance. The original guidance prior to vaccine or when the vaccines were first rolled out is that there was no minimum time between between infection and getting vaccine. So if you waited that 10 days of your isolation period, you could then go get the vaccine. Now if you are vaccinated and you get infection, you are kind of getting a natural boost to that immune system. So there's really no good guidance. You can I think offhand, most of my colleagues are probably recommending a few weeks, anywhere from 2 to 6 weeks, because again, you are getting that natural boost as well.
But plan on getting it.
Yeah, I think it's right now the recommendation is to get it. Again, I think there's a lot of different opinions on that. Would you need it? But I think the safest thing, because we know these vaccines are so safe, is even if you've had it, probably to go get that additional dose at some point in time.
All right, let's get to some final thoughts. Dr. Coomer, I'm going to start with you. Just what advice do you have for folks who may be getting a phone call from their physician team that may have to defer a surgery, and just what do you want folks to know?
Yeah, I think they need to know that we put a lot of thought into that, and we don't want to do that. We don't really, these are deferrable or postponable cases. But we realize they're not truly elective. When people are getting an operation, they've changed their work schedule. They've asked family to come into town to be there for them. That changes a lot of things. It's a big deal, right? And you think about, and this is our business, right? So the car industry has had a difficult time, and they can't make cars fast enough, didn't have enough chips. And people get upset about not getting their car. Well, guess what? They're a lot more upset when they have their surgery canceled because it's the gravity of that situation. So we are trying to get back to normal as fast as possible. Like I said, 50% cut most of this past 3 weeks, 25% this week. We're hoping to get even less than that next week. We want to get back to normal business. That's what we do. That's how we make our cars.
That's how you make your cars. Dr. Coomer, thanks. Always good to have you with us. We
Thanks for
appreciate
having
you
me.
very much. Dr. Hopkinson, final thoughts for you today.
Fingers crossed. We know around the nation the cases are going down. We think in our community they're still pretty high. Haven't necessarily seen that downtrend yet. We know hospitalizations will be lagging behind that peak by a week, 10 days, 14 days. So we are still seeing great hospitalizations and a good number of deaths as well. Continue to be safe and protect yourself and your bubble. Very good and insightful questions today. If you haven't been vaccinated, go get vaccinated. If you are due for that booster, please go get that booster as well. Let's keep everybody safe. Just as Dr. Coomer said, hopefully as we move out of this cold weather into the spring and summer, things will be more normal. Case rates will be down, and we'll be able to get back out and be more, I guess, like last year. At that time when we had very few patients in the hospital. And that's the important thing, is we want to keep you and your loved ones out of the hospital, keep you safe, keep you from having to deal with the tragedy that we saw before with your story on the morgue and all of that stuff, Jessica. So.
Very, very well said. Great message. Dr. Hopkinson, thank you. Dr. Coomer, we'll see you soon. And thank you so much for being with us today. 18 hospital chief medical officers from around the region will bring us the very latest on the COVID surge and be here to answer your questions tomorrow. And coming up Thursday, we're going to go back to the morgue. After we showed you video from inside our morgue this past week, a lot of you had questions, understandable. So we are going to help get some of those answers. As we leave you today, testing for COVID continues. Make sure you get tested if you think you might be exposed or you might be sick. Here is an update on the debate over home tests, when to use one versus when to go ahead and get a PCR test. Have a fantastic day, and we'll see you tomorrow.
The data continues to evolve, but unfortunately in the wrong direction. Recent data shows that patients can be symptomatic and falsely negative on these rapid tests for the first 2 to 3 days of their symptom onset when they would be positive by a PCR. So they seem to be not performing as well as we would have hoped. A positive result gives you a lot of information, and so there's value in taking it and getting a quick positive, especially if you're having delays in PCR testing availability in your region. I think the challenge is that the negative result has become less trustworthy, especially in that first day or two of symptoms. So we want to be very careful in interpreting that negative when you're symptomatic.
Subscribe to our Morning Medical Update and Open Mics with Dr. Stites podcasts. Now everywhere podcasts are available.